Good afternoon, everybody. We're going to start the webinar now. I want to welcome you all to the Essential Substance Abuse Skills webinar series. My name is Jenny, and I'm filling in for Kate Trams again today. Hoping she'll be joining us come June. But we've invited Sean Baer to come and speak on clinical evaluation and treatment planning today. This training series is brought to you by the National American Indian and Alaska Native Addictions Technology Transfer Center, or the ATTC. We're one of 4 national focus centers serving the ATTC network, which also includes 10 regional centers and a network coordinating office. To learn more, please visit our website. This series is designed to be a broad overview to assist in preparing for written alcohol and drug certification examinations, to enhance existing knowledge, and to improve overall competence and treatment outcomes. Please be aware that this series is not meant to stand alone, and previous education and training is necessary in order to pass alcohol and drug certification exams. Please check out our other upcoming webinars in this series, as well as the American Indian and Alaska Native Behavioral Health Series, which takes place the first Wednesday of each month. Topics or speakers, so feel free with suggestions to put those in our Q&A pod, or by contacting Kate Trams at the email address or phone number provided on this slide. Our center is NADAC certified and educational provider, and CEs are available on request for a $15 fee. A request form is available for download in the Files pod in the webinar screen. If you look in the lower left, it's down there. And I'll also be sending this form in a follow-up email to all who attended. Immediately following today's webinar, you'll be redirected to our GPRA evaluation. GPRA stands for Government Performance, to evaluate our events in order to comply with this act and provide improved performance assessment and accountability. This survey asks about your satisfaction with the event and will take less than 10 minutes to complete. We thank you in advance for helping us improve our programming. You'll be muted for the duration of this webinar. So if you have any questions about the presentation or about Adobe Connect System, please use the Q&A pod by typing them into the field at the bottom. We will try our best to address questions at appropriate points during the presentation. We would also like you to be aware that this webinar records participant attention time in another window. The system will record your participation as inactive, which may be reflected in the number of CEs received. Today's webinar presenter, sorry, this didn't get updated. Today's webinar, my apologies, is Sean Baer. He is a senior behavioral health consultant with the National American Indian and Alaska Native ATTC, and one of our very good trainers. So we're happy to welcome Sean Baer today. So thank you, Sean. If you have any questions, okay, skipping that. Oops, something funky happened, so hold on, and I will open up our slides for today. Hold on, we're just trying to get these slides lined up. Sean, would you like to begin?
Sure. Okay, hello everyone. My name is Sean Bear. I work with the National American Indian Alaska Native ATTC. Um, you'll see here that we're looking at the clinical evaluation, treatment planning, goals, and objectives. We'll go a little bit more about what these are, but you'll see from the beginning here it starts out as how do we define treatment planning, understanding the correlation between assessment and treatment planning, a little bit over the overview, the history of it, a little bit of the history, using the MATRS model and progress notes. So then, what is treatment planning? So we look at it as it's a result of a collaborative process between the client and the counselor. So both of them together develop the goals together. Um, if you look at it long before, people would come into a treatment center and they were just giving a treatment plan that everybody followed right off the bat. But later on, it changed, so all of them have to be individualized. Looking at and how do we develop it is we look at the results of the ASI or other instruments may be using, the clinical interview, and collateral information from family and such, and presenting problems. So other examples you might want to use is looking at cultural demographic information, Native American cultural values, their beliefs. There's also scales out there which you might be able to use for that. You also may want to include a spiritual advisor or a spiritual leader if necessary. So then when we're looking at obtaining and interpreting all the relevant assessment information, you need to integrate these into the treatment plan, and especially to address substance use and mental illness. So first addressing those pressing needs that are more important, evaluating client motivation, identifying the goals, selecting interventions, making sure that they're measurable and that they're observable, and follow up and modify treatment plans as necessary. So in treatment planning, at a minimum, the treatment plan needs to address substance use, as well as issues related to treatment progress. Remembering that you may want to bring in relationships with the family or significant other, maybe employment, education, some of their spiritual needs, the cultural needs, ceremonial needs, maybe their health concerns, and legal problems. So if you're looking at, let's say, for instance, working with couples or something, of course, you may want to work with relationships. With the family, you may want to work with that, plus with the family, it's like maybe education. If they are not working, looking for a job, maybe they might be referred to an employment agency or looking for jobs. Education, maybe they need to look towards getting educated or going to college or something like that. Spirituality, they might want to actually go out and find some person to either get those needs met. So legal, they might need to making sure they pay their fines or making sure they make their UAs or meetings with their probation or parole officer. So then when you're obtaining and interpreting all the relevant assessment information, remember to return to the client resources and barriers to treatment when assessing cultural relevant information. Um, Making sure that you remember how the impact the family systems have on treatment decisions and outcomes. If you're looking at cultural specific stuff, how the family and community needs are met, or how those functions actually work there, and not in like the immediate environment, but within the community and family, peers and such, and maybe how they're viewed. So you'll see here that when you're looking at the stages of change, which is developed by Prochaska and DiClemente, the treatment process, you're looking at motivation, and you'll see how it goes from pre-contemplation to contemplation, preparation, action, maintenance, hopefully not relapse, but remembering that relapse is doesn't always have to be, but it is placed in the recovery process. So then once there's a relapse, it goes back around again. But once it doesn't meet that anymore, it kind of goes outside. So then pre-contemplation is normally when a client, or before it was a client, doesn't see there's a problem at all. They don't see what's going on is an issue. Later on, maybe they get picked up so many times or get in trouble or actually seeing problems within a family or community with others. So they begin to think about whether they have a problem or not. So then they move into contemplation. They're thinking about getting help. And when they kind of deciding to actually get help or to get treatment or anything like that, they move into preparation because they're getting ready to go to treatment. They're getting themselves ready to decide work, things like that. So then they get into treatment, and then they're into action phase. So then they're really working on abstinence and such, working on other problems, maybe or issues that are going on in their lives. So after a while, it goes into maintenance where they're working on themselves. And during this time, they may find out that there's more things to work on than substance abuse or other things that they didn't realize was there before. Hopefully, it doesn't happen, but remembering that relapse can be part of the process, but it doesn't have to be. One thing I would suggest is for those who do relapse, there's going to be a little bit of differences in how to deal with that because for one thing, you don't want to push the client away. To me, whenever there's been some kind of a lapse, um, and the client actually feels very bad about it, to me, I've always seen that as a good sign. To me, I've always seen not seeing that they did anything wrong at all. That can kind of be a dangerous sign because they see it as normal. Um, when they did feel bad about it, I would kind of talk to them because, a lot of times what happens is people make mistakes no matter what it's going to be. But usually the thing that gets clients and people the most is themselves and the way they beat up themselves. So a lot of times people don't need to beat up on them anymore at all. So sometimes what they've learned from it may be more important and how to deal with that later on. So then remembering confidentiality, remembering how to utilize effective communication styles, um, maybe how the client sees the assessment findings, the roles and expectations of others potentially involved in treatment. If you're looking at like a small community or family dynamics and stuff like that, how would you see this? How do you see a small community family dynamics that may be detrimental or a little bit dangerous to confidentiality. That's something you need to look at. Um, they always kind of look at what is the most dangerous to confidentiality, and different things. But normally it can be more dangerous with a large family because you cannot always control who's going to say anything. Looking at nonverbal communication, how your cultural awareness regarding the customs, your eye contact, your voice, the tone of speech, your personal contact, um, the factors that may affect the client's comprehension of the assessment. Looking at language, is there going to be a language difference? Sometimes with older tribal members, they might have a little more difficult time with English. So then looking at English, translation might be a little bit different. Or, there can be many things. It's not just the language, but how they believe, how they see the world, how they might be following older traditions or belief systems. So when you're looking at client and significant others, remembering to use effective communication styles, um, different methods to elicit feedback. So when you're doing this, look at remembering the effective communication styles. Whether it's verbal or visual. Using DVDs or art, using audio such as a song or drum or some kind of music or even tones. Methods to elicit feedback. It's important to be mindful of cultural ways and customs, remembering that time is not always the same for natives. Okay, so examining the treatment implications in collaboration with the client and significant others. So you're going to look at what treatment modalities are available, your client placement criteria, cost, if there's any, effectiveness of various treatment models based on current research, implications of various treatment alternatives, including no treatment. Remembering that um, from an assessment or somebody coming in, it doesn't mean that everybody who comes in for an assessment actually needs treatment. So that's what some of these things are designed for, and where to place a person. Maybe sometimes they just need education. Um, Whether they might need one-on-ones or family and group counseling, whether they might need medication management. Looking at the red road, our more cultural or traditional approaches, community community-based programs, whether they need a 24/7 program, intervention, an assessment program, whether you have access to recovery, the ATR. So then one thing you should always remember in placing clientele is that when they return or even before they go, they already know the expenses that is going to come to them after it's all done. So it's like if there is going to be an expense that should already have been handled before, and also looking at when a client returns from treatment, what are you going to do with them? So perhaps there's another program where they can come back to or go to and stay there longer. Something that's going to help them get either more education, a job, a place to stay, or even just to be safe. Because you never really want to have a client get out of treatment and have nowhere to go. So then again, you're looking at the motivation process, of the stages of change, go remembering how that these move from pre-contemplation to maintenance and hopefully not relapse. So you need to prioritize the client's needs in order they will be addressed. So those things that are um, needed the most, you place those at the top. You can even number them with the client, remembering that this has to be done with the client. It's no longer just something that the client um, or the counselor says this is what you're going to do. It's an agreed upon um, kind of like a contract with the client and counselor. So, looking at Maslow's hierarchy of needs, one thing I've tried to use that was with clients who are worried about going to a residential program, an inpatient program, because a lot of times you look at the bottom three tiers, and the bottom three tiers, when they're in an inpatient residential place, all those things are met. And it's designed so that when they go there, all they really need to work on is the top two. So looking at safety and security, the legal issues, functional impairment, uh, remembering that looking at the hierarchy of needs is the bottom tiers need to be met before they can proceed. So looking at that as like a lot of times residential programs kind of meet those so that they can focus on themselves. Looking at your level of your client motivation, the treatment needs of a diverse populations, how to write measurable outcome statements. The counselor needs to understand how to work with a person from a different culture, understand specific cultural or the person that's being served, remembering that not all Native Americans are traditional. Some may be assimilated or bicultural. So remembering to meet those needs, remembering that those who are assimilated might not want anything to do with the tradition, or those with who are very traditional might not want to use certain things that might be used in treatment because they don't see them as culturally sensitive. So then, when you're looking at strategies, remembering that the level of your client's interest in making specific changes are important. Treatment issues with their diverse populations. For instance, let's say we had a client and the staff may need to evaluate this person for either medical monitoring or medication. Looking at the clients with a holistic view, their spirituality, the community, extended family, their communication styles, um, their physical selves, emotional selves, and your mental self. So when you're coordinating treatment activities and community resources, making sure that you prioritize the client's needs in a manner consistent with his or her diagnosis and existing placement criteria. So looking at what the community has, what's around your area, are there other resources around the community that you can utilize for certain things? For instance, let's say that they may have some kind of trust issues or something like that. So you could send them to work with the equine therapy, looking at the contributions of other professionals or self-help support groups that might be helpful. One thing to remember is like with AA, not all Native Americans are going to really want the traditional AA. They may want a Native American version, or maybe even to utilize a talking stick or talking group or something like that. It's kind of interesting because I've heard this quite a bit, is many Native Americans not wanting to go to traditional AA. What's really interesting is because actually there was a story. If I can't find his name real quick. There was a story about AA, and long ago, when one of the either Bill or Bob had passed away, there was a young guy or an older guy. I think his name was Eugene B. Short, and the one who had still living stopped Eugene by the fence, or stopped by there, talked to him, said, "You're Native American, right?" He goes, "Well, yes, I am." He goes, "Oh, there's something that we never really told many people, is that a lot of the principles that we use in creating AA was actually done by borrowing from Native American spirituality to form it." So I thought that was really interesting because even though a lot of natives may think that AA isn't for them, if they were allowed to realize that AA came from Native American spiritual principles, they might be a little more inclined to use it. There's also the Native American version, if they choose. Looking at your current placement criteria for ASAM or other materials you might use, the importance of the client's racial or ethnic culture, their age can be very important, developmental level, their gender, their life circumstances, just to address their needs.
Hey, Sean.
So if they're,
Hey, Sean, this
yeah,
is Jenny. Somebody has just made a comment, and I think it's kind of interesting if I can jump right in here. Sometimes significant others are not invested in being involved in treatment planning because they see the client as the problem and the only problem. Any strategies to involve them, or if this is the case, is it better to work with the client first in treatment planning and then bring the family in later?
oh, of course, it's the treatment plan normally isn't going to be done exactly with the family. So you're going to look at that information that's going on there, but with the treatment just for the client, him or herself, you would work with them separately and then do the family separately, and at some time to bring them together. Hope that answers your question.
Thank you, Sean.
Okay, so making sure that you develop with the client a mutually accepted plan of action and methods for monitoring and evaluating that progress with the client and counselor. So then looking at the relationship among problem statements, desired outcomes, and treatment strategies, looking at whether you have long term goals or short term goals. You're evaluating methodology, making sure that it is observable. You might be wanting to look at how the client begins to change the behaviors and thinking. Even though you might not be able to see the thinking, you might see how the client has changed their speech or how they do things. Short term is normally 1 year or less. Long term is usually a year or more. But one thing that's really important with goals is what I've always utilized is the client, him or herself, to pick a goal far off into the future. So then when you're looking at that, you can also help them set some goals beyond treatment. So then what do they want later on in life? And you work kind of backwards in a sense to the present where maybe they want a great house or big house or family and such. So then, of course, maybe they need to get a really good job. And to do that, maybe they need to get educated. So then, in doing that, maybe they need to study and work hard in college. But maybe they also need to get into college. So, a lot of these things, when they're going on, they're able to see improvement. And it's like rungs of a ladder. They just keep going up and up, and that allows them to see that. A lot of times, I think that if clients can see that they're moving ahead, it helps them to realize that they are moving forward and not stagnating. It's so hard, I think, to look off into the horizon and keep walking if everything looks like a desert. So then, remembering the confidentiality rights and stuff like that, the federal, the state agency confidentiality regulations, as well as tribal, the requirements and policies, looking for maybe resources for legal consultation if your client needs it, effective communication styles, remembering that treatment plan is considered a legal document. So also looking at whether the federal, state, or tribal jurisdictions, those concerns might come into play when it comes to confidentiality requirement and policies. In states, the federal um, requirements and confidentiality are a lot higher and stricter. But one thing to remember is even though you're working with a lot of different confidentiality laws and regulations, that if you always go with the highest of each, you're normally okay. So then we get into reassessment of treatment plan at regular intervals and or when indicated by changing circumstances. Revisit the cultural assessment tools, revise treatment plan as needed, see how the client's doing. One thing that I really advise for a lot of people who are developing treatment plans is to set the client up for success, not failure. You want this person to be able to meet those goals. Don't give them goals that they're not going to be able to meet. In a way, it's like if they're not meeting them, they may feel that they're not worthy, they're not doing as well. They may look at themselves and internalize that. So remember, if there's any problems, maybe the treatment plan may need to be changed. Some things might not have been working. Maybe certain things didn't work out. So then remembering that they can be changed. So then we look at treatment planning. Well, some people might think they're meaningless and time consuming. Some people might ignore them. Some people might have utilized the same plan but different names. But remembering that other organizational considerations is looking at requirements of the funding. What does that entail? What needs to be done? Making sure that there's not a bunch of duplication, or there's really no duplication in the files. What technologies might be able to utilize? Is paperwork useful in treatment planning and process? Something with the client being able to write down things as well might be very helpful. That way they can actually see that. Remembering, if you look at long ago I believe that was an earlier 2000s and stuff, they still had treatment plans that as soon as the client came in, they all signed the same time. Everybody would follow these certain things within the treatment, so they kind of lumped them all in one bunch. But remembering as time went on that they were changed so that they had to be individualized. Um, program driven plans, client needs were not important. Um, plan often included only standard programs, individual group sessions, little difference among clients and treatment plans. Maybe they had to attend 3 AA meetings a week, complete 1, 2, and 3 during group or during their treatment time, attend group sessions 3 times a week, meet with the counselor 1 time a week, complete a 28-day program. So these are examples of a treatment-driven plan. They may often include those services immediately available to the agency, often do not include referrals to community services or parenting classes. But today, there was, during that time from between then and now, there was a great shift in this. So then all treatment plans had to be individualized, remembering that there are many options available and they're custom and styled to fit each person. So then, especially if you're looking at Native Americans, there's going to be a big difference, because normally, like in studies and such, most studies were done by Caucasians, maybe certain age groups, but there's been very little done with Native Americans. So it comes into their religious practices, their belief systems, the practices that they met. Maybe some might have had been talking to an AA person, but the way they perceive it may come from a biblical standpoint, but really maybe a traditional person doesn't want to follow that. Although there are traditional people or all across the continent that may utilize both. Some tribes are like that, but even some people within certain tribes are like that. They became sized to match the client problems and needs. So then if you're looking at this part here, is when you're looking at that, is like, what does the counselor need to discuss before developing a treatment plan? Where do you get the information and guidelines and tools to be used, etc.? So then possible source of information might include the probation reports, screening results, assessment scales, collateral interviews, talking with the family, peers, people in the community. But, remember, make sure you have a release or consent to do so. So then remembering that, looking at a biopsychosocial model, it's like normally they have a biological part, psychological part, sociological part. Looking at this is, does your client have a car? Can they access public transportation? Normally in many Native American communities, it's like that are rural, they might not have the transportation. So it's very good if a program would be able to provide that for them. Might depending how close they live, though. Looking at how available drugs and alcohol are in the home or in the neighborhood. And I'm looking at the medical status, or psychiatric status, family social status. Remembering that, okay, looking at individual treatment plans is it leads to increased retention rates, empowers the counselor and the clients. So then with the treatment plan, it's also telling what the client's going to do, but how the counselor is going to be there and help them through that, and maybe how other community members might be doing that, or how the family might be doing that, whether they might need to seek out additional help either from elders or something like that, somebody else to speak to. Um, to the ASI, um, are utilized to fit the client's services to his or her needs. A lot of times, I don't know if many of you are probably maybe using the Native American ASI, which is using AccuCare. So a lot of those will ask about what tribe they come from, or their traditional, or what religion they practice, such like that. What is included in a treatment plan? So then we look at that, and it kind of comes from the problem statement, and adds the information gathered from the assessment, goes into a goal statement, has the objectives and the interventions. So then looking at that, if you look at the components of a treatment plan, your problem statement, the goal statement, the objectives and what the client will do, and the interventions and what the staff will do to assist the client. If you're looking at that in other terms, you have action steps, measurable activities, treatment strategies, benchmarks. That's what I've always liked about mini goals. It allows the client to be able to see that they're moving forward. Review of that is you're looking at the problem statement again. So then the information you gather from the assessment, whether what diagnosis, what level of care, if they have support, they're financial stable, maybe if they're educated or not, whether if they have a vehicle or not, all these things like that. But you're also looking at the strengths, remembering. From that, you develop a goal statement based on those problem statement. So then the objectives move forward what the client will do, and their intervention is what the staff will do to assist the client. So then looking at part of the discharge plan components, remembering that the client's strengths are reflected, participants in planning are documented. One thing that the strengths are reflected, it reminds me of when I was in the military, and as a team leader, I had to write notes for the soldiers underneath me like every 2 weeks. But I had learned from a different place than I was at the time. And we were always taught, where I was before, not to just talk about what's all good or what needs to be worked on. What we had to do was, even if there was something or everything was good about this soldier, when you can use it as a client, there's always something to be worked on. That not everybody or not anyone is perfect. So there's always something to be worked on. So if you're able to allow the client to understand that a little bit more, maybe they might be a little more accepting in the way that you might write or something like that. Okay. Considerations in writing. All problems are identified, including all problems, whether deferred or addressed immediately. Each domain should be reviewed. A referral to outside services available are a valid approach to addressing the problem. Remembering to be non-judgmental, no jargon. It's kind of interesting because a lot of Like if you're looking at employment things, and I work in the EAP, I had checked on a lot of performance evaluations within the organization, and I found of a lot of subjective material in there. And if you look at things like that, they would ever go to court or something like that, subjective material is always taken out. So if that's all they had in there, they have no case for it. A lot of times they have to be objective. So those are things you can really see. Remembering that the MATRS, and you can utilize this whether they're measurable, attainable, time limited, realistic, and specific. So then looking at measurable is objective, and interventions are measurable. Achievement is observable. Measurable indicators of client's progress. So remembering with MATRS, with the M, it's measurable. So it's objective and measurable. With attainable, you want to focus on improved functioning rather than a cure. Identifying the goals attainable at a level of care provided. Revise goals when needed. So time limited, remembering that the treatment progress isn't going to last forever. So at the end of that, you want to be able to meet those, but normally maybe afterwards they might have a plan that goes far beyond. So that can be part of the aftercare and how they're working towards that. Because remember, you want the client to be able to meet these goals. Realistic. So can the client realistically meet these goals? Are they achievable? Consider the environments, the supports, maybe their level of functioning. So looking at specific, remembering that you want to be specific in the interventions and what they need to do, as well as what the counselor is going to do to help the counselor is going to do to help the client. So the MATRS test, is it measurable? Can it be documented? Is it attainable? Is it time limited? Is it realistic? And is it specific? So then treatment planning overview is you conduct an assessment, you collect client data and information, identify problems, prioritize those problems, develop goals to address those problems, and remembering the MATRS, whether it meets the MATRS test. Okay, so we're going to be getting into documentation, and I'd like to stop at this time to see if there's any questions. I'll give you some time.
Okay, we have another question, Sean. Susan writes, is it a good idea to give a client a questionnaire to start the process of treatment planning with questions designed to address those goals that the counselor might see?
I guess it could be helpful, but at the same time remembering that it's individualized. So then a questionnaire might not always be able to meet the needs of the client. So then let's say that the counselor says, you need to do this, but the the client says, no, I don't want to do that. So then that's going to find some difficulty there. But I'm thinking that, so what's recommended with Native Americans is you definitely have, whether abstinence or something like that in there, like for the very first goal that has to do with substance use, but also remembering that if they want to, they can bring in more cultural things, whether maybe they need to go to ceremonies or they need to go to sweats or something like that. If this is something the client wants and wants to put in there, those can be added to the treatment plan. Is there any more questions?
I don't see any more right now, but if you have any questions as we get going, feel free to just fill in on the question and answer box, and I will jump in and ask Sean, okay? Thank you.
Okay, that'll work great because I don't see the questions popping up here. Okay, so then we'll go ahead to documentation. These are some, you're looking on the right, those are some examples of some of the notes. Remembering there's a lot of different notes out there. I've always tried to utilize a SOAP note. Stands for subjective, objective assessment and plan. I do know that the BERT note is, it's behavior, interventions, response, and plan. I think the NAP has something to do with therapy, I believe. But looking at the documentation, you want to include the type of session it is, what level of care the client is in, the date, of course, definitely the client's name, your client's name, and the counselor signature and credentials. Remembering that the basics of documentation, I guess looking at making sure it's date signed, it's legible, make sure the client's name is on there, or unique identifiers, whether it has a start or stop time, content of the session, client responses, progress towards goals and objectives, specific problems and goals and objectives addressed, interventions used to address problem goals and objectives, and add new problems or goals and objectives, but also looking at the plan, like possibly either a working plan where it goes through treatment process, or also what they're going to be working on until the next session. So then remembering that your entry should be your professional assessment, continued plan of action. So remembering, like with the SOAP note, the subjective, it's always kind of weird because the subjective has more to do with how the client sees it. Objective is how the counselor sees it, and then what is assessed during that time, and then the plan. So then, and it also describes how the client's doing. What are the outcomes of the interventions? What are those behaviors you observe during that time? progress towards a goal, and completion objective, how it's going. So in summary of this is um, you need to obtain and interpret all the relevant assessment information, making sure you explain the assessment findings to the client, provide the client with clarification if needed. You can ask the client whether they understand this or it makes sense. Examine the treatment implications in collaboration with the client and others. Making sure your client is ready and making sure you prioritize the client's needs in order that they will be addressed. So then you formulate mutually agreed upon goals and ways to measure those. Identifying appropriate strategies for each outcome. Coordinate treatment activities and community resources with the prioritized client needs. Remembering to inform the client of confidentiality rights. Sometimes this is great to do it every time, every meeting you have. Reassess the treatment plan at regular intervals. So is there any questions with notes? For one thing, I believe it's if you have a format for either a SOAP note or something like that, it's really good to follow. That way you get everything on there that you need to.
No questions right
What?
now, Sean. I'm sorry.
Yeah, that's one thing that was very important, I thought, was if you have a format of how to write a note, I think that would really be helpful because let's say, for instance, someone doesn't have the experience in writing notes. They might not put the information that's really needed in a note. Remembering that subjective might think that they can be subjective during this time when it's really the client's subjective information and then the counselor's objective. One thing I would like to say is like usually with um counseling sessions, one-on-ones, even groups, um I've always tried to make them a little more lively. Um Especially like in group or something like that. I've always observed all the clientele because a lot of times we may lose them. And what I used to do is to observe all the clients in a group session, especially like you're presenting materials or making sure they get it. But sometimes the way that we learn to speak or use things in an academic atmosphere might be a little bit different in Native communities, or especially like with youth. I remember I was trying to speak to youth clientele, and I remember I looked at them and they just looked lost. I was like, "Wow, what did you just say?" But it's something to remember. So then, what I began to do was to change the way that I spoke to the clientele and also describing things a little more, but also observing the clientele and how they were actually listening, how they were acting, whether they seemed bored or happy or excited or really interested. And that's what I really began to look at is those things that are very interested because during an education and classes, I remember those classes I didn't do as well. And those were the ones where maybe a teacher, something professor may have been very dry and it was hard to follow along. So, but I remembered also those who were very good teachers and that I remembered a lot. And I wanted to learn from this person because then I began to utilize, different tools or changing things or how it might be to gain the client's attention more and wanting them to learn, but also them wanting to learn the material. So as I began to change it, make things a little more exciting, I realized that they were all paying attention all the time. If you started to lose them or seeing that they're getting tired, you could bring in some kind of activities or something like that in order to um, let them understand a little different way in what you were speaking about. For instance, when I was paying it, it's like we might tell our clients, it's like not all things um, you have to worry about because it's like we're not always just dealing with substance abuse or certain things like that, but also looking at emotions, remembering that there might be grief or things that the client's going through. So I always try to remember those things. Remembering that there's always um, the chance that a client may not come back again, or that there might be suicidality going on, or something like that. So I always try to give all clients something to look forward to remembering that they are worthy and pay attention to them. Um, so that's the way I've always tried to look at all counseling sessions, whether a group or whatever it might be. So I began to really look at clients saying hi, really talking to them, getting in where they're with them and smiling. Sometimes even just a smile might help them to realize that you see them, that they are noticed, they're there. In group sessions, it's like to use a icebreaker every time. I don't always just jump right into to work right like that. It's like I would actually start it out with something to break the ice, something to calm people down, and that really seemed to help. Any comments, questions? Okay. So then we'll move ahead. We get into a little bit about the ASAM levels of care. Okay, with normally with native communities, tribes, the ASAM isn't required. The only time that ASAM is actually required for Native American programs is if they're being referred outside into the state or something like that, or if there's some kind of a payment method that needs to be gone through. So then maybe it's for finances and stuff like that. So so a lot of times this has to do with referrals outside tribes. So then remembering that with the ASAM, it's clinically driven, not program driven. They do not involve prescribed lengths of stay, but promote a flexible continuum of care. Involve an interdisciplinary approach to care. Include informed consent, are outcome driven, and clarify medical necessity. So then remembering that when a client goes in, normally they are expected to be better off when they come out. Um, the levels of care, there's early intervention. This might include maybe education classes. It could be maybe OWI program, outpatient treatment program. There's also intensive outpatient. Might be partial hospitalization, such as detox or something like that. Residential or inpatient treatment center. There's low intensity, medium, or high intensity programs. There are those that are medically monitored. So then looking at the dimensions of the ASAM, and it kind of goes down just like this, is you have acute intoxication and withdrawal potential. So those will be rated. The biomedical conditions and complications, those will be rated. Emotional behavior, cognition, and complications will be rated. The readiness to change, relapse, continuing care, a continuing problem, and recovery living or environment. So all these are going to be are rated after that, and then level of care, beginning the 0.0 or 0.5. They can just be maybe a one-on-one counseling session or education. Patients, they might not meet the need for substance-related disorders or substance use disorders. Problems in dimensions 1, 2, or 3 are stable and or being addressed. So you get into level 1, and that gets into outpatient treatment. So then they might include individual group counseling, motivational enhancement, opioid therapy, family therapy, education groups, occupational or recreational therapy, psychotherapy, or other type of therapies. So then we get into level 1 outpatient treatment. So then with this, there's no withdrawal signs or symptoms. Biomedical concerns are stable, so if they're on medication, they are taking it as prescribed. Dimensions 3, A or B, and C and D. So there's no occurring mental health disorder. Psychiatric symptoms are mild. Mental health status doesn't interfere with treatment. There's no risk or harm to self or others. Dimension 4, with the outpatient treatment is A and B or C or D. So they have a willingness to comply. They acknowledge there's a substance use problem and want help. They're ambivalent about substance use, but they may not recognize substance use. So with Dimension 5, they're able to achieve or maintain abstinence only with support. When you're looking at this part, Dimension 6 is either A or B or C. So then they have, it has to do with their support environment, inadequate support system, but willing to obtain a support system. Their family is supportive, but needs intervention to improve chances of success. So then you get into level 2. And if you've looked at this, when we're talking about the dimensions 6 and then 5, 4, 3, 2, 1, that goes into the dimensions of the ASAM. But you'll see at the beginning, what we talked about was a level of care. And then you have like 1 through 6, and there's usually boxes to the right of that, or sometimes there's just a line where you can add a number to it. So then those are what we're talking about when it talks about the dimensions for those who may not have worked with the ASAM before. Um, so then all these levels are going to have their own dimensions. So with the dimensions, you're looking at what is required for each. So level 2, again, there's no withdrawal. Dimension 1 anyway. Dimension 2 is biomedical stable or monitored currently with no interference. Dimension 3 is A or B. So abuse, maybe there might be abuse of family, diagnosed with a mental, behavior, or cognitive disorder that requires monitoring. Dimension 4 is A or B. They need structure. Need for repeated structured interventions. Dimension 5 is the symptoms intensifying and functioning deteriorating at lower levels of care. Dimension 6 or B. 6 is A or B. Current environment makes recovery unlikely. Current social situations not helping recovery. So then it kind of goes on. So then you'll see that it's not working. What I'll do here is it kind of goes on. So then the more severe it gets, the higher level of care that's needed. I'm not able to move ahead for some reason, but you'll see that with the ASAM, as the dimensions and the severity gets worse, so does the level of care.
Sean, that appears to be the last slide in this series. Oh, wait, here it goes. Yeah, I'm sorry. My computer's freezing.
Yeah, so is mine.
Maybe you can move now. Let's see.
Is there any questions over ASAM right now, or maybe over all of what we've spoken about? Any kind of maybe cultural things that might come into play or anything?
One
thing I would remember is like with assessment, remembering that there's been many Native Americans who have been diagnosed with mental health disorders when they don't have one. You'll see back, I think in the 90s, or there was a program, they were looking at a lot of the youth who were being placed in foster families. So then what they realized was a lot of these children placed in with outside the tribe with foster families most of them were being diagnosed with mental health disorders. So they wanted to find out what was going on. And what they realized was that many of these youth, even if they were babies when they left the tribe and would not have had the teachings or anything like that, when they were in the tribe or remember the environment or anything like that, when they were a baby, they grew up. But many of these kind of had a innate ability to either see or hear or sense things that the others didn't. Maybe the foster family thought they're mentally ill, so they took them to get an assessment, and they were diagnosed with mental health disorder. But along this time, what they realized was that this was something that was innate within Native Americans to be able to sense things that not all other cultures did. So what they termed that was, at that point, was the split feather syndrome, and that's when the child taken from the family would still exhibit these. So they're still having these abilities or gifts that others did within the tribe. And I know we did a round table, I think the other year, we addressed this with a lot of, there was doctors, psychiatrists, medicine people, and healers, spiritual people from all over the country. And that actually happened, and it was really good because we got to see people who are doctors. Maybe they came from the military and they had told stories about when a doctor or psychiatrist was assessing them, and they were writing down what they thought this person was exhibiting or possibly diagnosed with. So right away, some of them would stand up and say, no, this is not true. Maybe the, there was one doctor who had said that, yes, I do speak to animals. After this, like the psychiatrist said that had wrote down that, but hadn't realized that the person was reading what he was writing. So after that, he said, "This assessment is over. I'm not going to speak to you no more." But there was a lot of accounts like this, and I have met many medicine men that were diagnosed with mental health disorders that didn't have one. So later on, they ended up helping their people by the gifts that I guess was bestowed upon them. Let's see what else is there. Sometimes the way that a native client might grieve might be considered a little unordinary from the another culture. Any questions or comments?
Thanks, Sean. I'm not seeing a lot of questions now, but if anyone has any, please feel free to put them up there and I'll read them out to Sean. This looks like the end of the PowerPoint presentation, so feel free to wrap it up when you're ready, Sean, and then we can just kind of move on to the end of the session.
Okay. I hope this is helpful to all of you. Um, Again, my name is Sean Bear. Was my pleasure to speak to you all today. Thank you.
Oh, thank you. Jane points out it was great, and thank you so much, Sean. I want to thank Sean Bear so much for coming and teaching today. We really always appreciate his time and his insights as we get going. I'm going to end the meeting in just a moment, and when I do, there's going to be a survey that comes up that's the GIPRS that evaluates, the presentation today and allows you to give us feedback, which we really do appreciate. It also helps, people know that we're doing the work we're setting out to do. So every giver counts. I want to thank you so much. I hope to talk to you all and see you all back in a couple of weeks for the next behavioral health seminar. So have a great day. Bye.